incentives to physicians, at least on my take, I'd be interested if people agree with this, but my take of the evidence in the U.S. is they've been relatively ineffective. I guess they work better in the U.K., but I'm not sure what that tells us. I think it tells us international comparisons don't help much, but that's another story. But for example, the largest study I know of was in California, where a group of insurers offered incentives to physicians to achieve various quality metrics. The good news was everybody agreed eventually on the quality metrics, and they got some pretty good data on the quality. The bad news was, well, for one thing, the insurers weren't willing to put a ton of money into these incentives, and then when they didn't put a ton of money into these incentives, they didn't make that much difference. It did get attention to quality measures. There is a kind of economic solution here. You should pay for quality up to the point where the benefit of improving quality equals the subjective cost to the doctor. There must be some cost, otherwise the doctor would have already been doing the right thing. And maybe we're in the worst of all possible worlds, Pollyanna and Dr. Pangloss to the contrary notwithstanding, where the cost to doctors of changing behavior is actually greater than the benefit of changing behavior, but I wouldn't want to be quite that pessimistic. But that's the rhetorical question I ask at the bottom is the question I'm asking myself. Incentives for patients. Well, now here's where I get more positive, and want to come back to talk about how I would do how I would have done health reform and how I hope it changes. So part of the reason I think why a notion of using an evidence-based plan to change practice may be impeded is, well, essentially because patients don't really have a stake in the totality of the experience, I guess is the right way to say it. Certainly they have a stake in improved health outcomes, but they tend to be trusting on that, and it tends to be hard to measure it and hard to provide persuasive measures. But there may be some cost savings associated with those, with the greater use of evidence-based medicine. That's what we hear. But if it were me, and you told me you could save, let's say, $50 a month off your insurance premium if you join this evidence-based plan, given that there's both inertia and some disutility and some uncertainty, well, first I'd hang back anyway. Then when I had to explain it to my wife, I'd say, not only that, if we save $50 a month because we have all these pre-tax health benefits at Penn, and if this goes off of my cafeteria plan where it's tax shielded, I'm only going to save net $25. So the punchline here is that because of the way health insurance for the great bulk of the population is treated in the tax system, any cost savings are shared with the Treasury. That is a deterrent, I think, to getting consumers into the game in terms of moving ahead with evidence-based medicine. Fortunately, I'm really surprised and delighted it was there. There is I call it a vestigial remnant, but there's still something of an attempt to correct the tax treatment of health insurance in the bill, the so-called Cadillac tax. Now that's, for purposes of our discussion here, I think not so great because it's only going to impact the people who buy those very expensive plans, whereas if we want pressure to change the practice of medicine, you'd really like to have it be focused on more than the members of the Wharton Board of Overseers, who's ever going to have these plans. You'd like it to be across the board. Going back to the right way of doing it, which would be to cap or cancel the tax exclusion, would be better. There may be consumer preferences for these plans, but it's still unlikely to capture all of the Dartmouth inefficiency. Let me finish up here. Here's a downside, though. Suppose, and Tom may talk about this more later, suppose that comparative effectiveness research starts in a situation where nobody knows whether X is better than Y, and we establish, let's take the simplest case, that X is better than Y, and let's suppose X was initially the low-priced treatment option. If X is patent protected, if I'm the company selling X, then at least if I'm this capitalist profit maximizer, I ought to raise my price. My product is now a really good product. I'm going to charge, it's a more valuable product than people thought. People should pay money for value as well as get value for money. I'm going to raise my price, which means there can still be an improvement in societal efficiency, but it won't necessarily be cost containing. In fact, it could even be even worse or better, depending on your point of view, if research determines the treatment X is good for this set of patients and treatment Y is good for that set of patients, so that the treatment is now much better matched to patients of either type. both prices could rise because they're better value and it's less of a gamble. We may be able to get lower costs sooner than we get lower spending, I guess, is the punchline here. Conclusion, putting a nudge on the use of an expanded evidence base is going to be challenging, but I think that's a way to think of things, to at least make doing the thing that's supported by evidence the default option, and kind of along the lines of generic prescribing, make the doctor actually do something affirmatively. If you want to move away from the thing, you're still free, doctor, to do whatever you want. It's just that if you want to do the thing which we regard as not supported by evidence, you have to write down something about it. That might work. Hypothetical accountable care might help, but as yet no powerful model. Oh, I need to say here, I think my take, well, for one thing, the accountable care that came out of the bill is relatively modest and going to be a few experiments. It will probably apply first to organizations that are already integrated delivery systems like the Mayo Clinic and Geisinger. It'll be great for them, but that's not going to help Buffalo. And if it comes to Philadelphia, I was driving through the Lehigh Valley last weekend, and I wanted to go to Geisinger and say, why don't you people open up an office in Philadelphia? We need you. But I know there are reasons why they won't. Will the UPenn health system want to be an accountable care organization? Well, we lost $200 million a year for 3 years on our last foray into integrated delivery. And Jefferson didn't do diddly, and they ended up making a ton of money. So we may be a little skeptical. We shall see. Well, let me close with a politically incorrect Appalachian story, but I think it's probably the main message I want to leave with you. So there are interventions that I think work. I want to do a little commercial here for work I've done with Mary Naylor in the School of Nursing, using specially trained nurses for transitional care of severely ill elders, and connecting them with an experienced nurse who's able to help them manage the transition, dramatically lowers the rate of readmissions, and we did a randomized controlled trial, so the FDA of cost containment would give us a pass. But the more interesting story, when Mary writes her autobiography, we'll hear all about it, was how hard it was, having proved this works beyond a shadow of a doubt, to get anybody to pay attention. Now people are, Aetna is, Penn is, and even the Congress is. Of course, probably people already know the story. The story is a farmer bought a mule, and the seller of the mule said, this mule will do whatever you want, just whisper politely in his ear. So the farmer took the mule home, said, get up, and the mule just stood there. He said, get up again, the mule just stood there. Took the mule back to the seller. The seller said, oh, I forgot something. Reached over, got a 2x4, whacked the mule, and then he said, first you have to get the mule's attention, then whisper in his ear. And so we may need a 2x4 here to get people's attention, and then we can whisper politely in their ear. Thank you.